Hi, my name is Joshua Kaggie, and I am a senior researcher at the Department of Radiology in the University of Cambridge. And I'm going to be discussing today the validation of the exam project, which is a COVID-19 federated learning or machine learning project with the specific angle that this is validating the changes over time from the original exam training. So the number one problem with machine learning is that there are small data sets. And so this limits the ability for these models to be updated with appropriate weights to be as sensitive as possible. And so the aims of this project was originally during the exam one project, as I'll call it, was to help come up with machine learning training to help solve and predict some of the changes in patient populations that occur due to COVID-19. And so COVID-19 facilitated rapid global collaborations during this federated learning project. And the reason for performing federated learning is that healthcare data is tightly governed. And so oftentimes data cannot leave sites to ensure patient privacy. And so a way around this is the federated learning model, which pools collaborative sites to perform machine learning training and create a global model. And so this original project was called the exam project, or the EMR chest X-ray AI model. And it was developed by MGH and Brigham Women's Hospital Center for Clinical Sciences. And it brought data from 20 different institutions across 5 different continents together. So the benefits of federated learning is it allows for privacy and data control. So only model weights or gradients are transferred between the sites. And so not the actual patient data, but the machine learning training that occurs at each of the client sites are sent to a federated server, which then updates each of the client sites with new model weights, which then retrain. And so that provides patient privacy. And so it is easy to use by requiring the need for multiple sites. It has to be easy to use, but this improves the speed of data sharing across these sites. But most importantly, it facilitates worldwide collaborations. Quite oftentimes we are limited for every different continent, country, to every different hospital, university, to each of their laws, rules, regulations. And by limiting the data that gets sent from site to site, from country to country, this enables these global collaborations that would not otherwise exist to bring together larger and larger data sets. And so this allows more data from multiple healthcare institutions to be made available to improve the generalizability and overall performance of these AI algorithms. And so in very particular words, it allows for a distributed model for training, validation, and even testing. And so for the original exam project, it brought together 20 different sites across 5 different continents. And so we had a Nature Medicine publication based off of this. And you can see the map of the various places. Cambridge was the only site that participated from Europe. And the AI model brought all sorts of information together. So it brought demographics, vital signs, lab data, and importantly, the images, the chest X-rays. And it combined these into a singular model and predicted whether a patient, after being brought to the hospital based on these inputs, would then at 24 hours or 72 hours have either room air, low flow oxygen, high flow oxygen, mechanical ventilation, or even, and unfortunately, death. And so this was what the machine learning model would predict. And so it brought together all these sites, which had multiple and very heterogeneous data. And for the exam model, it had 5,172 positive PCR positive cases that were used in the training. So what we wanted to do in this project was a validation. And so we'll call this exam 2. So the exam project analyzed the first wave of COVID. So we classify this as before August 2020. And so further validation is needed for later time points. And we're able to bring more local cases. So within this validation set, we are able to more than triple our number of cases. And we can look at different kinds of variants based on the major variant at the time, even though we may not have specific data. And the treatments changed, and so there are the potential to look at the changes over time due to treatments and bring together more EHR biomarkers, more electronic health records as the patients began to get more thorough treatments and analysis. And so ultimately, which we are not at yet, we would like to perform clinical integration of these machine learning models. And so the cohort that we performed this analysis on at the University of Cambridge brought together 1,500 all positive cases. And this was newly collected data. So 1,800 altogether from Cambridge, but 1,500 post that first wave. So that first wave would be up until August 2020. And then we would look at August 2020 through April 2021, which had the predominantly wild type of coronavirus and alpha variant after the winter of 2020. And importantly, we collected this data and conducted this analysis and validation on the Rhino platform. And so looking at the cohort, just a simple visual look at who's coming in to the hospital. So this is what we are testing against. At entry, we had a much larger population during the exam two, during the additional waves, and so who had just room air, and far fewer who required any kind of low flow or high flow or even mechanical ventilation. So you can see right here at entry, the blue on mechanical ventilation, MV, versus the orange with later waves. The orange was much lower, significantly lower. And so it made it difficult for any sorts of tests for specifically mechanical ventilation. And these are ground truth results for 24 hours and 72 hours. So you can see that the percentage of people at 24 hours who were testing positive for coronavirus actually remained somewhat similar between low flow and room air. And so the PCR test does appear to be quite robust for the low flow needs. But again, our mechanical ventilation during the exam two periods was much lower. And so evaluating this data using the exam model that had been trained across this global cohort, we looked at these later periods and we binned the results and the predictions between room air and the various devices. And essentially, what we come up with is that we have an average area under the curve of 0.825. And so this is a measure of predictability. And so this was at 24 hours and 0.786 at 72 hours. And so the interesting thing about this is that these numbers for 24 hours during the validation, the exam two, were about the same as the original Cambridge data numbers, but also lower than the global average. And so the 24-hour numbers did not change. The 72 hours, though, I would say decreased significantly, or importantly, between 0.849 to 0.786. And so the later waves, the original model was less able to predict the results of the later waves at 72 hours. And so this is an important result in the sense that it helps validate why we would want to do retraining. This is simply data that has not been retrained, but simply tested the results. So spot checking, looking at various images. So we have room air, low flow devices and high flow devices and images of these patients. And so in terms of the images themselves, there's nothing that stands out tremendously as to what could cause a major difference. There could be additional analysis by looking at the effects of wires and looking at the effects of words on some of these scans. So perhaps you can see on the room air top left, there's the word mobile. And so it might be that the word mobile is actually affecting our result, because you're more likely to be on room air if you're in a mobile versus inside the hospital scanned. And so we had some model degradation at the 72 hours. And so the possible sources that we might have this from is there are different baseline oxygen measurements leading to different model performance. We looked at this, but it doesn't appear to have affected it. Cambridge had older patients, and the model performance does vary by age, but we looked at the correlation between age and model performance and did not see any clear correlations. And so we don't think that it's specific to the Cambridge data that we had a lower AUC with the retraining. The clinical practice and population differences do lead to different percentages of oxygenation required at 24 and 72 hours. These are striking in terms of the population differences. And this is probably just an artifact of the changes of COVID variants and of different treatment strategies. So the validation data included different strains of COVID and widespread vaccination causing different disease severities affecting performance. Essentially, the model performance differed by wave. And so it is unclear why, and it requires some further analysis, but this is also a result of changes in the hospital resources. For example, during the first COVID wave, there were limited ICU beds, and that sort of thing could have also impacted treatment or the oxygenation status. And so the analysis of that is still pending. So the important conclusion is that model retraining is necessary due to vastly different circumstances as occur over the different COVID waves. That we had different results because we had a larger room air group, which requires that retraining. And then the room air versus the other groups also had a poor result, which also is due to the changes of variants and treatment strategies and immunity or vaccines that had occurred during the later waves. But overall, we had similar 24-hour average result for AUC and a slight degradation in 72-hour results, which we have looked at now. So just to follow up after concluding on that project, we are contributing to ongoing projects. And so we're contributing to a brain aneurysm detection project and to a prostate MRI quality evaluation project, which are led by other centers. And within our center, we are also looking at federated learning in some rare lung diseases, which is funded by the Myrovitis Trust. And we'll be looking at musculoskeletal images within a HIT project. So within any of these 4 projects, if you are interested in being a collaborator, please contact us and let us know so that we can help you join the federated learning projects. And so final thank you to several different people for various different projects, and to Rhino Health and the NIHR Cambridge Biomedical Research Center.